All right. Thanks for joining. All right, let's get rolling. I'm Abe Korman, for those who don't know me. I'm one of the assistant professors here at Ohio State. And I thought it could be helpful and maybe interesting to just go through kind of like what a normal day in the life, at least of like an academic dermatologist, is like. And I wanted to open up for any questions that anyone might have because I have a couple of goals in doing this. One is I feel like mentorship can a lot of the time be lacking for a lot of people, and I want to make sure that everyone, especially those that don't have home programs, have good access to like a dermatologist to try to provide some type of advice. And then I feel like having these things recorded and put up, like in perpetuity, like on YouTube and things like that, are helpful, so we can kind of take hold of education for next generations and providing information social media platform. So I have a few slides to go through, but I want to make it a little bit more informal and just go through some of the things that kind of pop up. But we'll just get rolling. Just as a disclaimer, these are my personal opinions, nothing to do with OSU. So things that come up a lot in terms of like applying to dermatology, one thing is shadowing. I'll tell you why I put that in quotes in a second, but in general, kind of two ways to approach this. The first is dermatology interest group and just learning from senior med students and things like that provide existing mechanisms for signing up for available shadowing spots. So becoming an active member of these organizations affords you the opportunity to get on listservs, get updates, and get in for shadowing. The other thing, though, I think that's very effective is just to reach out directly to dermatologists for shadowing. You want to be a little careful with how you do this. You don't want to just like spam people and copy and paste the same email to like a million people, because that can be a little bit of a little annoying. But if you take initiative and reach out to someone and have a specific interest area, specific interest in their area, then it's not unreasonable to reach out to people. Just as a side note, it's kind of a rant that doesn't have anything to do with anything, but I think the term shadowing is a little ridiculous. Where everyone here is a medical student who's training to be a physician. I think when you're joining a physician like a dermatologist in their clinic, really you should be having the goal of working with them and learning as much as you can. You're not supposed to be a shadow. I want everyone who ever works with me to be active, seeing people, providing differential diagnoses, and doing biopsies, procedures, those types of things. Research. This slide is for anyone watching on YouTube, is a little bit OSU specific, but there's two important things that we kind of just want you to know. I talked about this with our medical student coordinator, and if you're wondering about, well, look, I need research to be a competitive derm applicant, which unfortunately is kind of the case nowadays. There's two venues that you can use to get involved. The ODA, which is number one, is very important, the Ohio Dermatologic Association. Every spring, basically, there's a call for medical students who want to present interesting cases, and you get to do a poster presentation at the meeting in the fall. It's really fun. You get to meet a lot of people. And so this is, again, just kind of keeping an eye out for a call for a request for people applying to these types of projects. The other thing that's also important is the MD student research projects, and those are a little bit more in-depth projects that happen every summer. And the way that works, again, or it's going to work at least this year, in the summer, there's going to be a call out to faculty, see whoever's interested in mentoring researchers. And then with dermatology interest groups help, a slide deck will be created, and then you'll try to match mentors with mentees. This is a little bit more in depth, but it provides some funding for the summer, so you can actually do like an in-depth research project and tries to match people with mentors who might have the same interest. Also, they're starting this year like a journal club aimed at medical students. I don't really know too much about it. This didn't really exist during my time, but it's going to be a monthly journal club spearheaded by senior medical students. Faculty might pop in, and just the goal of it's to kind of learn a lot of how to interpret data, how to create studies, meet some dermatologists, some things like that. I did want to focus most of this on talking about like what does it mean, or kind of what does it look like to be a practicing dermatologist. I'll preface this by saying I can only provide the academic perspective. As you probably know, there's private practice, there's academic. Private practice life is a lot different than academic. A lot of my good friends are private practice dermatologists, so if there's any interest, I'm happy to have them on our YouTube channel and kind of interview them, and you can kind of see what a day in their life looks like. The other comment from there, I'm an academic dermatologist, but I'm just one of many, many academic dermatologists. There's different niches in academic dermatology. And so my particular day in the life or schedule is going to look a lot different than other people you might work with. Just kind of as a background, you might already know this, maybe not, maybe it's slightly helpful, but three main pathways or fellowships that people pursue from derm path, Mohs surgery, and peds derm. So dermatopathology is a 1-year fellowship that allows you to actually read like skin biopsy slides. It's really cool. It's really interesting. You can actually become a dermatopathologist through pathology or dermatology. Really cool fellowship. Mohs surgery is a 1-year fellowship that allows you to perform Mohs surgery, which is a specialized type of surgery for primarily skin cancers, the removal and repair, complex repair of these large and complicated skin cancers. And then peds derm allows you or affords you the extra training to take care of pediatric dermatology patients. There's other like unaccredited or less formal niches that people kind of establish. So there's like cosmetics, rheum derm, oncoderm. People get specialty, develop specialty in nails, pigmented lesions, etc. Just for me, this just happens to be me. Everyone can do different things, which is why I think derm is so cool. But I happen to have niches in rheum derm, which is autoimmune dermatology. So this is patients with connective tissue diseases, so like dermatomyositis, lupus, scleroderma, vasculitis, etc. It's a really interesting type of stuff, at least to me. I also specialize in inpatient derm. That's really my baby, my focus, which is taking care of hospitalized patients with skin diseases. And I really like this because I feel like you really have to know a lot of internal medicine, a lot of medicine in general. You're taking care of the sickest patients who are very complicated. They have really high comorbidities or a lot of medicines. And you see the craziest things in the hospital, just the craziest things. And that's why I really like inpatient derm. I also kind of just fell into prison dermatology and underserved dermatology, but I really like both of these areas as well. Prison dermatology, of course, taking care of incarcerated individuals. And then I do clinical Latina where we take care of uninsured Spanish-speaking patients. So sorry, this is kind of small, but in terms of like my schedule, again, this is just specific to me, but just so you can kind of see like how an academic dermatologist kind of structures their day. The reason I like it so much is every day is really different. So the way it works, again, this is just me. This is just me at Ohio State. The first 3 weeks of the month, I have a set schedule. So every Monday, so like tomorrow, it's going to be an administrative day. So I'm not seeing patients tomorrow. So tomorrow I'm catching up on inbox. So I have to take care of, like my chart messages, emails from people about a million things. I have 4 meetings tomorrow. I do research, all that type of stuff. So what's kind of cool is that most places do offer at least a half day or a full day a week where you get administrative time. And at Ohio State, you get to kind of pick your day, which is pretty cool. I picked Monday, so it allows me to recover from the weekend. The next day on Tuesdays, in the morning, I do surgeries. In the afternoon, I do general dermatology. Again, that's another reason I love derm, though, because it just uses so many different parts of your brain. So in the morning, we get to do procedures like skin cancer, mole removals. I do a lot of nail cases, so I'll do like nail biopsies, nail removals, things like that. And then in the afternoon, you can just go ahead and see like general dermatology patients, skin checks, acne, whatever, whatever rolls through the door. What's also kind of cool is on the second Tuesday in the month, I staff resident clinic. So instead of going to my own private like general dermatology clinic, I go with 3 residents and they have their own independent schedules and we staff the cases together. And to the right, you see like the typical hours that these clinics and admin days kind of go. On Wednesday specific to me in the morning, I have a research half day, which is kind of cool, but it's because I'm into research and have funding to do so. But those are hours that I just plug away on research. If you're someone who's like, oh my God, that sounds absolutely awful, that's okay. You don't have to do that. If you're someone who's into that, then obviously do that type of thing. I love it because I really like doing research, kind of pushing the field forward. I really do a lot of inpatient research. So this is a half day where I protected time to just sit and think and write papers and work on problems and do chart reviews and that type of stuff. And then afternoon, I go and see patients. Thursdays is kind of just like a patient's day, just kind of grinding and seeing general patients all day. The exception is on the third Thursday, I go to Franklin Medical Center here in Columbus. It's actually like an outpatient center where they bus prisoners in from all over the state of Ohio and staff that clinic with 3 residents where we see incarcerated individuals for 4 or 5 hours. And it's a really awesome clinic, actually. Friday, I really love because in the morning, that's when I do my autoimmune derm clinic. It's very difficult. It's very high volume. These are kind of not your more typical derm patients. They're very complicated. We often see them with the rheumatologist at the same time. They're like on a billion medicines. They have a million medical problems, but it's cool. Again, it's not surgery. It's not gen derm. It's not research. It's not admin. It's just a different type of your brain that you're using and flexing, and that's what I think is really cool and really cool part of derm. And then in the afternoon, I kind of cool down and calm down a little bit with general dermatology clinic. What I think is really cool, though, again, about academics and why I love my schedule so much is this is what I do the first 3 weeks of the month. But then the last week of the month, everything's the same, except in the afternoon, instead of doing all general dermatology clinic, I actually drive to the hospital and do consults. And it's super cool because you just use a totally different part of your brain. In the morning on a Tuesday, I might remove some giant melanoma from someone's back. And then in the afternoon, I might go to the hospital and then see a patient with like Stevens-Johnson syndrome. So that's why I think it's really cool. Friday is my favorite day when this combo is kind of lined up because I see room derm patients, which are complicated, and then go to the hospital, which is complicated. And I just think that's fun. The one thing, you probably know the kind of stereotypes about dermatology having more favorable hours. We work standard like outpatient hours. With inpatient, the hours are longer in general, but one of the other things is you don't really get to close your notes in real time. So, usually like drive straight from clinic to the hospital, don't really eat lunch or anything like that. And then you kind of grind through it and then do like home and family life and usually do like late charting. So service weeks are kind of exhausting and a lot of effort, but they're fun. What's also cool is like just for me, the second Tuesday every third month, I go to Clinica Latina. So that's after a regular day of clinic or whatever. We have it on High Street, a Clinica Latina from like 6 to 9 p.m. where we see it's around 15 to 20 uninsured Spanish-speaking patients who just come in with tons of different complaints. It's a really satisfying, really rewarding clinic. You really help people. People come in with really severe skin disease there and don't have a lot of other people to help them or options. So it's one thing I do in addition to that. One thing you probably know is sadly, physicians in general suck at prioritizing their work-life balance, especially academic physicians. And just because of all the crap I'm involved with, I do a lot of after hours work, which I would discourage you from doing. Do as I say, not as I do. So like usually with charting and research and all these other responsibilities, I end up putting 30 to 60 minutes of work probably every evening and then weekday on emails and other stuff. And this is just a full disclosure. I would discourage you from doing this. Be better than me. I also work on clinical trials. If that's something you're interested in doing, clinical trials I think is super interesting. These are medicines that pharmaceutical companies are trying to bring to their audiences, so to these specific patients. And you're a physician who has expertise in that disease, and so it affords you the opportunity to be working on the cutting edge of these medicines and affords you the opportunity to provide these medicines to your patients. So, for example, right now I'm the lead investigator on a phase 3 trial of a company that's studying a medicine for skin lupus. And so it kind of makes sense because I run an autoimmune dermatology clinic for cutaneous lupus. So it's kind of just a win-win situation for everyone. So if I see these sick patients, I have this clinical trial that I can offer them and really give them hope. And then on the other end, I get to help the company actually move this medicine forward and hopefully get approved by having a large patient population to offer them. So it's kind of a you scratch my back, scratch your back type of thing. And it's really, really fun to do. Very time consuming, but fun to do. Most academic dermatologists here at OSU, we take call, believe it or not, 2 weekends a year. Typically what that entails is you are responsible for covering inpatient consults on like Saturday or Sunday, usually go in one or both days and round on hospitalized patients and staff with the resident during that time. Usually during your call week, you're also responsible for taking weekday transfer center call. That means that, like, say you get a call from a hospital in like Marietta or Southeast Ohio, somewhere far away that doesn't have derm, they often enlist our help because we have inpatient derm here. And so they kind of reach out to us for help. They reach out to us and ask us if we should transfer patients to OSU to kind of take over from there. Just real quickly, I don't want to take too much time, but when you're thinking about your time when you're a physician, at least in academics, maybe a little less so in private practice, the easiest way to think about it is by CAR-T. So it's like every second of your time can be divided up among doing one of these things: clinical, administrative research, or teaching. Clinical is just seeing patients. That's what they mean by clinical effort. And that's the schedule I showed you before. So that's when you're in clinic, you're with a nurse or medical assistant, you're just grinding through seeing patients, taking care of patients, doing biopsies, excisions, prescribing medicines, consulting with other physicians, that type of stuff. Administrative is, just meetings, planning, having specific roles or niches. So, for example, I direct our division of inpatient dermatology. So my administrative work is running our presence in the hospital. So meeting with our department leaders, but then the medical center leaders to have space and support, and meeting with hospitalists and anyone who interacts with our division of inpatient dermatology. So this is something, again, that's not like patient facing. It's not research. It's just kind of taking care of something from an administrative perspective. Research, obviously, it's doing research. We talked about that. I do inpatient derm research. We have some people who work on research with oncodermatology, pigmented lesions. We have a really strong surgical department who does a lot of squamous cell skin cancer research. And so that's, again, you're not seeing patients, you're just grinding out research. And again, you don't have to do that, but if it's something you're interested in, I think it's really interesting. And you have the opportunity to do it. You work with faculty, you work with residents, you can work with medical students. And then T is teaching. That's my absolute favorite. Honestly, if there was not teaching, despite everything else, I wouldn't do academics. That's why I do academics. I think it's super interesting. If you look at my schedule, at least, the reason I love it so much is I have so many of these different niches and places where I get to interact with and teach residents and medical students. So, for example, in my procedural clinic, I have a resident with me most of the weeks, and it's pretty cool. I'll have them from all training levels when they're first year to when they're third year, PGY2 to PGY4, and I'll teach them surgery, like my surgical tricks on, like suturing, surgical indications, how to take margins, how to do nail cases, that type of stuff. Like I talked about, I get to staff a resident clinic, which is cool, where they pop in the room, they see the patient, they come out, they present to you, and then you go in, you discuss the case, and then you go in together. I have a resident with me most weeks in room derm clinic, which I think is really fun because it's fast paced. It's hard. You can see it makes the residents a little uncomfortable, which is good because it pushes them out of their comfort zone, and you get to really see them grow from their first year to their third year. Like I alluded to before, we have 3 residents who go to prison clinic. Prison clinic is awesome because it's not weighed down by a lot of bureaucracy and administrative BS that a lot of other places have. It's just pure medicine, very appreciative patients, a lot of problems you can really help fix, like skin cancer and inflammatory medical dermatology. And so I get a chance to teach residents in that setting. And then consults, there's always 1 resident, sometimes 2 residents on consults. It's the same thing. You roll in, they've had the chance to see and think about the patients in the morning. You staff the cases with them in the afternoon, and you go see the patients together. What's also cool is, that's residents, but in all these same clinics, I have medical students come in, with the highlighted exception of I also have medical students with me in my general dermatology clinic. In some ways, but I really like teaching both residents and medical students. In some ways, it's almost better to teach medical students because medical students are less differentiated, so to speak. So you end up teaching a lot of medical students who don't go into dermatology or don't do the type of derm that you do. And I think that's cool because I feel like if you're a good teacher and you teach a wide array of things and pathologies, you can really benefit the physician in training, no matter what type of physician they end up being. So I think that's really cool. And all these clinics have medical students in them. So that's it for kind of the canned or presented portion of it. I hope you find that slightly helpful. I didn't want to make it too long because I don't have a long attention span myself, but I hope that's kind of helpful into like a glimpse of like how we do our day. So hopefully that's slightly helpful. The medical student leading this sent me a chat of some questions. I'm just going to open up, and I don't know if you can see that. Let me see. There we go. Hopefully you can see that. So these are some of the questions that were kind of submitted to me, and I'm going to read these now for the first time and just answer them honestly, and then hopefully it's helpful to you. So what specific experiences during med school helped you confirm that derm was the right specialty for you? Yeah, that's a good question. I actually got interested in derm very late. So I wanted to do neurology, and I got interested in during my third year of med school, just when I did a 2 week teaser rotation. The things that I liked about it were the breadth of diseases that you could see. So, you can pop in one room and treat acne, bread and butter. And then the next room you go in, it's vasculitis. And the next room, it's dermatomyositis. And the next room, it's a kid with mastocytoma, and then you go to the hospital and you see something insane. So the types of experiences that really inspired me to do it was the breadth of the pathology that you could do. Um, and then just the different types of things you could do. A lot of times in medicine, you have to train in a specific area to become an expert in a specific thing. So, if you want to do surgery, general surgery, you become a surgeon. If you want to think and, use your mind for a lot of things, you become an internist. Dermatology is kind of like a mix of a lot of things, and that's what I like. You can still cut, you can still, take on complex cases. You can still do run of the mill, kind of more standard cases, not easier, but more just kind of run of the mill. And that's how I kind of knew it was a specialty for me. I have a short-ish attention span, so I'm not someone who wants like a 45-minute visit. Like that's not quite my thing. So I like that derm, you can still establish really nice long-term relationships with people, but it's not like a long slog of a visit. Next question, what do you recommend med students to do during their preclinical years to prepare for a career in dermatology? Honestly, I know this might not be the most popular advice ever, but I would say beyond your preparation for like applications and stuff like that, obviously you have to bolster derm research, derm quote shadowing and experiences and derm mentorship to have a successful application. But the thing I would recommend though strongly is to get a good foundation in everything medical. I think to be a really good dermatologist, you should be a really good physician. I can't tell you how many times it comes up that some piece of knowledge that I picked up on internal medicine or OB-GYN or psych, like things that you just would never imagine, end up helping you as a dermatologist. So my advice would be really soak it up as you can, even preclinically when you're not seeing patients. Soak up any piece of knowledge, any nugget of information, especially high yield things like from UWorld and things like that. They always, always, always come back to help you. And then especially when you're on your clinical years, soaking up every little piece of information there, because when you're a physician and when you're in dermatology, that's all you see day in and day out. So you don't know or remember the perspectives of other specialties and physicians anymore. So while you have that opportunity, really take it. What types of research projects are most impactful for med students interested in derm? What advice do you have for approaching faculty? So typically the most impactful in terms of application is going to be like more like of a longitudinal project. Like case reports, it's cool to have them. I think it's nice to have like one or two or more than that. But when someone's like reviewing your application in terms of impact, it's always going to be something that's a little bit more longitudinal in nature. So for example, if you did like a survey study or like a data analysis study or an intervention study, that's going to be the most impactful because it showed that you stuck with the project and really took it from A to Z, start to finish, and you helped someone. Of course, from like a non-application perspective, I think those are the most impactful because you actually helped someone. I really feel strongly about doing research, not just for the sake of like BS and padding your application and stuff like that, though I get the game must be played, but for like helping someone. And I think you can play the game and have a good application, but ideally if you create a project that helps someone, at the end of the day, you actually make a lasting impact in derm, and you can do that as a med student, which I think is pretty cool. How do you get these projects? We talked about some Ohio State specific ones earlier. Cold emailing back in the day when step one wasn't pass fail and derm was slightly less competitive was an option. It's harder now. For example, if I open my email right now, I have like probably 10 emails from medical students seeking research projects, and I get at least 1 to 2 a week. People are just overwhelmed. So cold emails, you can go for it. It just doesn't always go anywhere unless you have a specific idea. If you just reach out to someone, you're like, hey, found you on your academic website. Can we do research? The person's gonna be like, okay. I mean, like, what do you want to do? It can be more helpful if you reach out to someone and you have a specific, not necessarily idea, but at least like niche in mind. So say you're like someone who's interested in skin of color derm or room derm or hair derm or nail derm or whatever. finding someone who does that niche and reaching out to them. I think it's a little much to expect someone to have like a specific project generated. I mean, if you can do it, go for it. But I think it's a little much. But at least having like a niche generated, reach out and be like, hey, I saw you do nail dermatology. I'm really interested in that. Is there any research that we could collaborate on, something like that? Shadowing, quote, shadowing, same idea. So if you're like, hey, I really like hidradenitis suppurativa, and I found that this person does HS at this institution, reach out to them and be like, hey, this is a disease I'm really interested in. Do you mind if I join you in your HS clinic? Rarely, in my opinion, unless the person's kind of a not so kind person, is someone going to say no? Like again, I have people reach out to me all the time, and when they're like, hey, I found that you do room derm, can I join you? I'm always like, yes, like as long as there's space, you can come in. I think the more the merrier. What should med students focus on during their derm rotations to make a strong impression? Um, I don't know if this is a popular opinion or not. I really think like reading ahead of time, like knowing some stuff is important. Obviously, you're going to train in derm residency to become a dermatologist, but I think being read up shows that you're willing to learn. So, doing like the AED basic modules are really high yield. Just reading up on like DermNet, Z or whatever that New Zealand one is called. And just learning like basic lesions, like what are the most basic benign lesions, like seborrheic keratoses, cherangiomas, dermatofibromas, all that type of crap. Knowing like basic derm so that when you see those lesions, you at least can identify them. Learning how to go through like a differential diagnosis for something, I think always makes a really good impression with me. And then trying to have a plan makes a good impression for me. I used to do this all the time, and I still note that, and it still makes me chuckle because I used to do this myself, where someone will give like an amazing like soap note presentation, and then they get to like the assessment and plan, and they just kind of like grind to a halt. They're like, patients presenting with a 2-week history of this growing lesion. It's a well circumscribed brown papule on the right forearm. And then they just stop. And I'm like, well, yeah, like, what's your assessment and plan? Like, don't be afraid to say, my assessment is, I think this is a dermatofibroma. Plan is, I think we should reassure the patient. If you're wrong, that's okay. Like, I like when I feel like a lot of other faculty feel that way. Like, at least put yourself out there and generate a plan. Don't just grind to a halt. I remember I used to do that. I remember like one attending specifically kept pointing it out to me, like, oh, shit, I didn't even realize I was doing that. So really just try to just come up with something. It's okay. You're not supposed to know everything. No one knows everything. Just come up with a plan. All right. As a med student who's interested in both derm and rheum, I'm interested in learning more about a typical day in the rheum derm clinic. What conditions do you treat? Is there any avenue for a dermatologist to get further training? Okay. Yeah, rheum derm clinic I think is really cool. There's a bunch of, I shouldn't say a bunch, maybe like 10 to 15 rheum derm clinics nationally. Most of them function by having a dermatologist and a rheumatologist both in the same clinic. That's how ours run. I work with a rheumatologist. We both have a half-day clinic. It's Friday morning once a week. The conditions we treat are conditions that have overlap between derm and then rheumatology, meaning that they have skin and internal manifestations. So lupus, dermatoscleroderma, vasculitis, erythema nodosum. I'm missing a lot. I know neutrophilic dermatoses, encapsulated, all those types of things. And the reason why we have this type of clinic is because it's interesting to see these patients together, but we know that outcomes are actually improved when you see them together. So it's really awesome for these patients who are sick and need both dermatology and rheumatology to come in. They see me, they see the rheumatologist I work with, and when they leave, they have a cohesive plan from both of us. We literally pop out the room and be like, hey, what do you think? And sometimes we go in literally together. And I just think it's awesome care. The patients love it. They leave knowing like what's up and what the plan is. In terms of special training, there are some fellowships nationally. I know Harvard has one. UCSF, I think, has one. Cleveland Clinic has one, I believe, for rheum derm fellowships. They're unaccredited. They're not like ACGME accredited, but they work with like world and like national experts in rheum derm conditions, and they train you for a year. You get to see like all their insane cases and you learn from them. There's also complex med derm fellowships. We have one here at OSU where you get to learn that type of stuff. I didn't do any of that stuff. Maybe it's a little unpopular of opinion, but it's kind of like, it's almost like a self-fulfilling prophecy. I mean, if you start getting interested in that and you start seeing those patients, you become a de facto expert. I don't think 4 or 5 years ago I started as some expert in these types of things, but when you start seeing 4 to 5 patients with dermatomyositis a week over 4 years, you become, pretty good at it because you've seen it. And when you see it, you're not intimidated by it, and you know how to approach it, and you know how to tackle it. So whether you want to do that training is totally up to you. It depends upon your residency program. I think if you have a strong residency program, you don't need to do it. If you don't feel like you have those exposures in residency, you can do it. But I just kind of learned kind of like on the job, so to speak. And I feel fairly competent now. All right, those are all the questions that came through the email, I think. So let me stop sharing. Does anyone who's on have any questions for me? Hopefully this is mildly helpful.
Oh, yeah, I have a good question.
Yeah.
So I know your perspective is, you work in an academic program, but in your opinion, like how does a dermatologist day in the life be different who works in a academic-based community program? And there's pretty robust ones like Riverside in Columbus or Henry Ford in Detroit with their own residents, clinical trials, like rotating med students from like small universities. So really, what's the biggest differences?
That's a good question. The problem is I don't know because I didn't train there and I don't work there anymore. My inclination would probably be exposure and volume of severe pathology. Again, to your point, it's not like places like Henry Ford and Riverside here locally in Columbus aren't seeing those cases, but they're probably not going to be in general like the largest tertiary or quaternary like referral centers for the most difficult and sick patients always. That's a generalization. That doesn't mean they're not extremely skilled. It just means that when you're at these big flagship institutions where we have a billion specialists, that's where a lot of community people want their people to land. So that would be one thing I would think about. To your point, clinical trial access is available in all those settings. Pharmaceutical access is probably even better in private practice in those community associated health centers. There's a lot of restrictions on beyond trials of like pharma coming in and like giving samples and giving like speaker talks and those types of things. But yeah, other than that, I don't have a great answer, but I have that's someone we could have on in the future, and you give that question to them, they'll actually give you a real answer. But yeah, because you have like these quasi academic programs where you can be like private practice, but then also still have residents who work with you. But that's my impression. And then when I used to work with Ohio Health residents back in the day, the structure was often a little different for them. So, for example, they have a dedicated consult service now, but back in the day, they would come and rotate with us on consults. A lot of the clinics that they trained in were a little bit more attending focused than resident focused, meaning that like a lot of the residents would rotate in attending private clinics rather than having their panel of patients. Not for better, not for worse, just a different style. So that's kind of a non-answer, but we can get someone on here who knows what they're talking about.
That was a great answer. Thank you.
I only know my thing, unfortunately. But Durham is just so different everywhere. Anyone else? Hopefully this is mildly helpful. And then whoever is watching this one day on YouTube, hopefully it's mildly helpful. Let me go. Yeah, no, that's all I got. All right. Thank you for joining. Feel free to reach out. I'm not sharing that slide anymore, but reach out to me anytime. I really feel strongly about people having like decent mentorship. I didn't really have that back in the day when I was a medical student for a long time, especially deciding to get interested in derm really late. So if you need like need to at least be pointed in the right direction, just let me know. Otherwise, let me